so much, Matt. I appreciate it. Good morning, everybody. I know you were all really excited to get here at 8 o'clock on a Friday to listen to a lawyer first thing off. And I can't tell you how many of my healthcare clients are terribly excited to get a phone call from me, and their heart generally in their throat when they do. But today we're going to be talking a little bit more about innovation technology, and then I want to talk a bit about this idea of justice. I think the political context and social context in which we're operating, I think, provides an important overlay for how we can think about disruptive innovation going forward. I'm going to give the standard disclaimer that I am here in my personal capacity. I'm not speaking for the University of California or my employer, so all tomatoes direct them directly to me. I want to start with an obvious provocation. Every healthcare organization is, at some level these days, a tech company. Think about your biggest cost centers. Think about your biggest assets. Think about your biggest liabilities. Think about your IT department and their annual budget request. Now, back in 2011, this was predicted by one of the big venture capitalists, Mark Andreessen. He said, struggling with my slides here a little bit, but he said software is going to eat the world back in 2011. Well, software has eaten healthcare here in 2018. Every piece of data that we have, no matter where it's coming from, whether it is from our smartphone, a wearable, a digestible, what we're searching and purchasing online, demographics, who we are, the grocery stores or the proximity of them in our neighborhood, what's in our EMR, our clinical records, imaging, structured, unstructured data you can't even see, that data is precious because it tells us something about our care journey, and it can be used in very important ways to inform how our organizations treat our patients and how much risk we can accept in the new value-based healthcare system. One of my colleagues, Dr. Atul Butte, who's the head of computational health sciences at UCSF, says, data is frozen knowledge. We use data, and it's just sitting there, sitting in our EMRs, and we are, and all over the healthcare organizations that we have. It's sitting everywhere, but we can use it and process it to train AI, to train various AI systems to come to different predictions about outcomes in healthcare for our patients in their care journey. This requires a profound shift on the business side of healthcare. How many of you have an AI department? That's a couple, right? How many of you have met with your chief AI officer recently? Right? We are behind. We're deeply behind in healthcare because, and we're going to need to partner with the tech sector in order to catch up here in the era of AI. This means new consolidations, new partnerships as health and tech, healthcare and tech continue to merge, because all of the AI infrastructures and all of the advanced technologies, those belong to companies that have multi-billion-dollar, almost trillion-dollar market caps. They don't belong in healthcare. And so if we're going to advance, we're going to unlock this data to find this frozen knowledge to inform better what risks we're going to take, how to get upstream so that we can help our patients stay healthier earlier so that we're costing less. It's going to require partnering with new entrants into the healthcare system. Amazon has a secret health team. How many of you have heard of this? It's called 1492. Very subtle name. Apple recently introduced a new innovation, and we're using it at UC San Diego healthcare system, and I think many of you are as well, where Apple is making healthcare records available through an API, and you can put them directly on your phone. So it's kind of a blue button type innovation. Microsoft is doing AI-powered healthcare. Google DeepMind, we'll come back to. Google is using the same technology and infrastructure that it did through search in order to tackle healthcare. But today's inquiry, I would suggest to you, is about critically examining the pivot to tech-driven healthcare. And I want to issue a few provocations to get us to think a little bit about this. I want to talk first about a little bit what's behind our turn to tech. Second, I want to talk a bit about what the challenges are in realizing value. Technical solutions are not value, right? The journey to value is a much longer process. Third, I want to talk about how we distribute the benefits of innovation in a healthcare system like ours. We are innovating on top of a deeply unequal healthcare system, and it has escaped nobody's notice. We don't have one healthcare sector, we have many. And people's care experience is very different depending on what part of that sector they're in. So I think how we are going to scale the value from all of this new technology that we're innovating, how do we scale that within an unequal system and with a system as fragmented as our healthcare system? I think this introduces important questions of justice, particularly distributed justice, that we're going to have to grapple with. How many of you are familiar with the single payer debate? That's not going away. That is a debate about winners and losers in healthcare. That is not a debate about single payer. That is about how are the costs and benefits of an unequal and fragmented healthcare system, how are those benefits to the public, to the ill, to the employed, the underemployed, those who are contributing their data to the effort that I just mentioned, who bear the burden of disease, what is the benefit to them of the healthcare system? So let's talk first about another thing that's been in the news. Amazon, JP Morgan, shockwaves felt throughout healthcare in America. And of course, it was because of JPMC and Berkshire Hathaway, right? That's the combo, right? Oh, it's Amazon. That's the big dog, right? Why? Well, there's a broader disruption that's happening here that I was alluding to earlier. Tech companies like Amazon and others bring something very special to the table. They do things very well that we don't do very well in healthcare, and they do them at scales that are truly, truly incredible. How many times? My wife probably orders from Prime four times a day. It's ridiculous. I mean, literally, like, we have Ring, so you see somebody like walking up to your door, and it's always someone dropping off an Amazon package, right? And the things that I used to get from Amazon a couple of years ago, it's totally changed, right? 10 years ago, we would get books, and then we would get groceries, and now like she got like fertilizer for the lawn. I mean, you can get anything from Prime, right? Whole Foods merged with Prime, so now they've collapsed that supply chain together. Man, wouldn't it be something if healthcare could look a little bit something like Prime and Whole Foods? Why do people love Prime and Whole Foods? It's instant, it's easy, it's endlessly customizable, massive choice at a pretty darn good price. By the way, the opposite of that, if you took like every single one of those things that I just put up there, instant, easy, customizable, choice, and price, you could use the opposite, the antonym for each of those words to describe the way that a lot of hospitals work, because that's just the way that healthcare is. It's a little bit different. Let's talk about capital. Amazon has a fortress balance sheet. So does Berkshire Hathaway, but Amazon has a balance sheet like nobody's ever seen. This is one of the world's great fortunes that's been put together. Sorry, 1 second. These slides are running on AI, so they're getting ahead of me a little bit here. And they can take risks that most healthcare organizations can't take. But let's talk about AI, because that is really the value differentiator for a lot of these companies. I want to talk a bit about Andrew Ng from Baidu, and then hopefully pause these slides. There we go. That's better. So Andrew Ng, I don't know how many of you have heard of him. He's kind of one of the godfathers of artificial intelligence, and he runs a very famous lab at Stanford. He helped start a little company called Baidu, which makes Amazon look like a mom and pop store. And in his one of the lectures that he's given on AI and how AI is moving forward very, very quickly, what he has said essentially is anybody that wants to compete with us at Baidu, and he moved on to start a different venture since then. He said, you are hopelessly behind. And you are hopelessly behind because we have an infinite amount of resources, paraphrasing, and we have a massive head start. We have the best AI minds that we recruit globally for, and we've concentrated them all within our organization, and we have an endless supply of data. So good luck trying to compete with us if you want to build your own AI system, whether it's in healthcare, it's in sales, it's in retail, and whatever it's in. You're better off partnering with us. I think that reality is something that is certainly coming true at this point. So AI works on population scale data. AI is a data play. These are the 90 startups. I don't know who's seen this slide before. There are 90 AI startups in healthcare. Lifestyle management, risk management, research, diagnostics, imaging, hospital room management, mental health, drug discovery, wearables. These are 90 different AI startups that are trying to make sense of data to train machines to do thinking for us. I want to introduce you to one called Zebra. Zebra will look at a scan, an image that a radiologist will look at, except this machine doesn't, the average radiologist can like think about 30 or 40 diagnoses at once. That's about their differential as they look at an image. ZebraScan is a machine that has been trained on many millions of images, and then a human tells it on the test set whether it got the image right or whether it got the image wrong. This is a glioma, this is a fibroma, this is some kind of a pathogen. And then over time, the machine teaches itself to actually be better than any of its human trainers. And then it uses that underlying algorithm, the logic that tells it whether a particular image is something pathological or benign, and then it applies it to data, new data going forward. That AI-based system is available for $1. It's $1. Like literally, Starbucks, what is a cup of coffee at Starbucks these days? It's like $58 or something, right? You get like a mochaccino, forget it. You have to do it on layaway, right? This is $1. Now, we've already seen a lot of radiology work move offshore. We've seen it move remote, right? Because images can be read from anywhere. But this is $1, right? You can't get anything for $1. I don't even think Taco Bell has the dollar menu anymore, right? And this is a radiological scan that is being read. Now compare that to a human radiologist, sometimes who's working at 3 in the morning, God knows where, exhausted, working at stuff that comes kind of first in, first out, not put in order of priority. So whether it's a scan where you're looking for the possibility of a tumor or looking at a scan for a much less serious disease, right? You can actually, risk management folks have studied this, and if you look at when radiologists make mistakes, it's junior radiologists late at night reading a scan when they're towards the end of the shift. So radiology right behind neurosurgery and cardiac surgery, that's the third highest liability for malpractice. ZebraScan, man, why couldn't we just use this to prioritize the images that come in? Radiologists, read this first, spend your time here. This one doesn't look too serious, you can get to it a little bit later. Or get a second opinion. It costs $1. AI to prevent sepsis. How many of your hospital systems struggle with sepsis? Right? It's a killer. And you have what? A couple minutes, an hour maybe, to start getting fluid and start containing the symptoms before you have a real serious problem. AI can predict sepsis much more reliably than almost anybody else in an emergency room. They can take a quick look at the symptoms and they say this person's at risk for sepsis. You get those 10 minutes, you may save a life. So let's talk about, this is all very fascinating, right? We've got $1 scans, we've got sepsis. How do we scale this stuff? And how do we actually drive adoption at the interaction between the patient and the provider? How do we get value from all this tech? Well, let's talk about Watson and MD Anderson. How many of you are familiar with that story? Amen, right? This was the cover of the Wall Street Journal that day. Not a great day. But I want to give you a different narrative of Watson's foray with MD Anderson. They spent $62 million short story as Watson didn't work. A bunch of people lost their jobs. But this is the challenge that we have in the era of AI. How do we realize value from novel technology? And how do we nuance the complexities of delivering our technical innovations into actual value? And how do we start to take these risks as large, complex institutions that aren't used to taking these kind of enterprise risks? Yahoo and Amazon and others, they're used to taking these kinds of risks. They have the capital, they can do it, and they have the risk profile. But what we need to do is we need to think through not only using our data to train systems, to come forward with actionable insights, we need to move that to a clinical application layer, and lastly, to better outcomes. This is a hard thing to do. And this is what Watson struggled with doing over at MD Anderson and why it was such a scandal. The other part that was such a scandal, and the reason that a lot of people have cold feet about some of these large technical forays, is that it was like $62 million and the darn thing didn't work. Like they had to pull it out of the wall, right? It gets to some interesting points about all of us. And how many of you have Google, don't raise your hands, and Amazon and others knocking on your doors? We have a growing divide in healthcare where we're going to have a set of winners that are brand new, who are going to reap the benefits of all this innovation. And we're going to have a new set of losers who are likely to struggle to receive the benefits of this innovation and may bear some of the disproportionate cost. Much of this innovation, the Amazons, the tech companies, that chart of 90 AI companies, all of this innovation is happening at the edges on top of a very fragmented and deeply unequal healthcare system. don't have to tell any of us. This slide's in red because we are bleeding red in our public financing system for Medicare and Medicaid. I want to talk to you about a case called Perea against Dooley. I'm a lawyer, so I had to talk about at least one case. How many of you heard of this case? This is a case from the Mexican American Legal Defense. There's one person. Thank you, sir. The Mexican American Legal Defense and Education Fund sued the State Department of Healthcare Services. Their allegation is that we have a separate and unequal care system for Latinos in California. Literally, separate and unequal. Like, that is, those are some big words. The data actually supports many of the points that they've made. Put aside the legal merit of the case, but there is good evidence that the system is chronically underfunded, there is poor access, and that many of folks post-Medicaid expansion, Medi-Cal is an overwhelmingly Latino program in California. Well, let's contrast this underfunded and quite stratified from a racial and demographic standpoint system with all the innovation and excitement that I've been talking about. All the Watson and the AI and all the amazing things that Baidu and Amazon want to do with us. How are we going to scale all of this amazing innovation and promise within a system where we struggle with the basics and we struggle to have an equal system? All the AIs that I'm talking about, they are trained with public data. This is data populating an EMR, and if you're a hospital that has 70% of your inpatient admissions are Medi-Cal, in some sense, there's a major public interest in that data. But what is the public benefit to be realized out of some of these large-scale transactions if you partner with an Amazon, or you partner with Google or Baidu? I want to bring you over to England, Google DeepMind. I don't know how many of you are familiar with that case. The Royal Free Hospitals in England, they have a totally single-payer system. And their single-payer system, they had one of their big hospitals give over 1.5 million identifiable patient records, the whole medical record. Not like one scan, not one image, the whole darn medical record for 1.5 million people. And they turned it over to Google DeepMind to do AI. This was a large-scale use of public data collected in a public hospital system with public money. But they really couldn't communicate what the benefit to the public was going to be. Well, what are we getting out of it? Well, DeepMind's going to build some brand new AI system. Well, who's going to benefit from that? Not necessarily the people from whose data is being contributed, or the public that's funding the underlying work. This leads us, I think, to important questions of justice in healthcare. As we continue to converge between healthcare and technology, I think you're going to see increasing demands for more distributive justice. Distributive justice meaning who has the benefit and who has the burden. Who bears the cost and who soaks up the benefits, particularly the public, who's contributing a lot of data, the ill and the underemployed, and those who bear the burden of disease. These questions are coming, and not just from a socialist like me. They're coming because, that was a joke. They're coming because this is what's behind the debate on single payer, in my view. The debate on single payer is not really about single payer. It's about what is the appropriate return and what is the appropriate distribution on a public investment. What is a fair distribution of the goods? It really is a question about discerning public goods and distributing them. The same political demand that is behind single payer is at work across the healthcare system. And you're probably feeling these tensions in lots of different disparate places. Tax exemption. How many of your boards, if you're a nonprofit health system, have tax exemption and tax exempt status on their top 10 issues? Well, it better be. Tax exemption used to be considered a public subsidy in exchange for charity care. Well, we're not doing a ton of charity care anymore. Now it is going to be reimagined as a subsidy in exchange for affordability and value, of bringing that technology from and innovation from the periphery into the core of operations where it benefits the most amount of people. As you're considering doing mergers and affiliations between large health systems and large tech companies, this is the story of MD Anderson. This is the story of Watson. Now, the criticisms of these deals will sound a lot like privacy or anti-technology, but what's really happening here, these are questions about how the benefits of the arrangement are going to flow. How does the public, how do our patients benefit in really concrete ways? If this is data about poor people and their experience in our healthcare systems, and it creates a valuable product, will those people benefit in some concrete way from these arrangements, and discerning that in advance and putting it into the agreement. So as we scale to truly what I call a tech care system, How do we scale our mechanisms for driving the benefits of this innovation broadly throughout an unequal system? How do we have governance that is truly community-based to incorporate the standpoints of those who may be traditionally absent from decision-making? Some of this is susceptible to technical solutions. AI to solve disproportions, AI that's focused on the agenda of the people who were behind or those that represented, whose interests are represented in that litigation I spoke about earlier. Um, these questions are coming, and they're coming very quickly. I cannot tell you how many times a week at our health system we get a knock on the door from someone from one of these really, really large new entrants into the technology space, from the technology space, entering into healthcare, wanting to partner with us on some level. But the same political demands that are sweeping across the country behind some of these other movements in single payer and elsewhere, they're going to influence how we partner in this space. We have to do it, but if we do it thoughtfully, I think we can have some success.